We're very excited now to hear highlights from the folks who carried this out, the folks who looked at the lessons learned from the Gender-Based Violence Initiative. We're going to start with Dr. Elizabeth Rowley. Elizabeth is a public health professional with over 20 years of professional and academic experience in the international development and humanitarian fields. She currently works in PATH's HIV/TB program, where she provides technical leadership for gender and gender-based violence-related activities in Senegal, the DRC, South Africa, and El Salvador. Dr. Rowley led the AIDSFree review of the Gender-Based Violence Initiative in the DRC.
Good morning. My name is Elizabeth Rowley, and I'll be presenting some of the contributions and lessons from the GBVI in the DRC. This is based on the AIDSFree team's work, review of 21 documents and individual and group interviews with 26 global and in-country stakeholders, some of which were conducted during a one-week visit to Kinshasa this past December. I'd like to mention that this work was undertaken with significant input and collaboration from a consultant to the AIDSFree project, Jean-Richard Mutombo. GBV and HIV are both significant challenges in the DRC. Although the DRC does not have the highest national HIV prevalence in the region at 1% among adults aged 15 to 49, its total population of 77.8 million means that there are large numbers of both adults and children who are HIV positive. As in many other countries in the region, a larger percentage of all HIV-infected adults are women compared to men. The DRC's very low ranking in the 2014 Gender Equality Index points to inequalities in education, political participation, and health, as well as limitations in women's access to resources and opportunities for economic empowerment. One frequently hears about brutal conflict-related sexual violence and other forms of GBV in the eastern DRC. But GBV significantly impacts women, girls, men, and boys throughout the country. According to the country's 2013-2014 DHS, 52% of women aged 15 to 49 have ever experienced physical violence since age 15, most often perpetrated by their husband or partner. There have been significant investments in GBV programs from the US and other donors in conflict-affected areas in the eastern DRC. But the GBVI was focused on Kinshasa province and what was then the full Oriental province before it was divided into smaller provinces. The HIV prevalence in Kinshasa province, 1.6%, and in Oriental province, 2.3%, are both higher than the national average. And GBV prevalence in both provinces is also high. These factors, as well as the location of key land and river transportation routes and a large number of existing PEPFAR-supported service delivery sites in Kinshasa and Oriental provinces, made these provinces especially appropriate focus areas for the GBVI. In the DRC, a total of $10 million was dedicated to GBV prevention and response programming for fiscal years 2011 and 2012, although some activities Thanks. Although some activities continued into fiscal year 2013 and onward. PEPFAR partners in country, including USAID, CDC, Department of Defense, and State Department, worked with four main implementing partners: FHI 360 Sea Change, Kinshasa School of Public Health, PSI, and the University of North Carolina. The GBV in the DRC had 3 national level objectives focused on coordination, service availability and use, and prevention, as well as 3 regional level objectives focused on GBV service availability, quality, and utilization, changes in GBV-related attitudes and behaviors, and capacity strengthening of social institutions, civil society organizations, and communities to respond to GBV. Being a PEPFAR-funded program, the GBVI Okay. Being a PEPFAR-funded program, the GBVI was intended to strengthen programmatic connections between HIV and GBV. SBCC efforts included messages specifically about the links between GBV and HIV. As well, clinical capacity strengthening ensured that GBV-related health services were in place at PEPFAR-supported facilities offering HIV services. The initiative supported the introduction of a GBV screening tool that was used in HIV and other health services to identify, care for, and refer GBV survivors for additional services as needed. And the GBVI also facilitated the training of national HIV telephone hotline counselors to refer GBV survivors from all over the country and even outside the DRC. For many implementing partners, it was the first time the connection between HIV and GBV was being made in a real way. One implementing partner told us, "It was the first time the donor had asked us to make a link between HIV and violence. For me, it was a prise de conscience, a starting point, and I began to really understand more in depth what these links are about and that we should talk about these links every time, not as separate things." Many of the key contributions of the GBVI have promoted the institutionalization of GBV prevention and response in national guidelines, clinical services, and community-level activities. These include the National Protocol on Medical Care for GBV Survivors, the development of training packages for healthcare workers and community actors, the GBV screening tool for use in health facilities, and the training of clinical staff. While the GBVI had a strong focus on GBV HIV integration, there were also linkages with other sectors. This included HIV hotline referrals to the legal and social service sectors. There was also the integration of GBV into services at military health facilities, the inclusion of GBV into youth life skills programs at military barrack areas, and GBV peer education for military spouses and children. One of the implementing partners adapted the Stepping Stones curriculum for the DRC context in order to promote dialogue at the community level about the links between GBV and HIV. The GBVI also supported capacity strengthening for media stakeholders to report appropriately on GBV cases and reinforce audience knowledge about the links between HIV and GBV. And the GBVI promoted synergies across sectors by facilitating technical coordination mechanisms at the national and provincial levels. Although the GBVI in the DRC had a relatively limited scope of 2 years and a relatively small budget, the accomplishments are impressive, and it's fair to say that the GBVI truly catalyzed change in at least 3 ways. First, it helped to demystify programming linkages between GBV and HIV. Second, these changes in the protocols, tools, and training are now institutionalized within the Ministry of Health National Reproductive Health Program. Third, it catalyzed change with partners outside the GBVI, including PEPFAR implementing partners who didn't receive specific GBVI funds, but who were able to integrate the new GBV protocol and training into their ongoing efforts to strengthen HIV service delivery, thereby reaching more people in a broader geographic area. Again, this was the first experience of working on GBV HIV integration for many actors in the non-conflict affected areas of the DRC. And there's a sense that the GBVI investments provided a well-designed push to create change in very practical ways. As one of the implementing partners told us, one of the biggest contributions of the GBVI was to show us that this work is possible. Something can be done. Thank you.